So today I'm going to be talking about acute coronary syndrome. I know it's a bit difficult to get engaged in this because there's so many of you, but if you can just type in the chat at any point, that would be really helpful and just help with engagement a little bit. I don't know how to get rid of this now. Okay, good. It's not a very, okay. So acute coronary syndrome. So we are talking today about the heart. And what we mean by acute coronary syndrome is basically, when we use the word syndrome, we mean a range of either symptoms or a range of diseases. And in this case, we mean that it's a range of diseases that's very acutely affecting the coronary arteries of the heart. So when we use the word acute coronary syndrome, we're describing a range of diseases that's affecting the arteries to the heart. The degree of obstruction to the arteries of the heart will affect how bad your symptoms are and will therefore affect how you manage those. In many high-income countries nowadays, it is the leading cause of death, mainly because of our lifestyle. So smoking increases your risk by tenfold, having generally a sedentary lifestyle. If you're male, you're more likely to have, question or hand up. Sorry, I don't know why my computer's getting so. Did you have a question? So general risk factors: smoking, sedentary lifestyle, and metabolic syndrome. Anyone know what metabolic syndrome is? Anyone? What's metabolic syndrome? So it's where people generally tend to have, good abdominal fat. So obesity is one of them, diabetes, hypercholesterolemia, so all of that. If you imagine someone having those risk factors, you're at higher risk of generally developing any cerebral or cardiac event. So this is what we mean by build-up by obstruction. So usually from the age of sort of 25 onwards, you get atherosclerotic plaques. It's just a normal part of aging that you'll get in your vessels. There are some things that will make that happen quicker, like smoking, having metabolic syndrome and all of that. So you get the typical obstruction that you get here in the second picture. And usually that tends to be a very chronic thing. It doesn't happen overnight. It happens over several years. But what then happens is, because those plaques are really unstable, you get a very turbulent flow. The blood that's going through is very turbulent. It can cause a break-off of the cholesterol plaque. Once you get a break-off of that plaque, your body tries to repair it, and in your body trying to repair it, you can get a clot formation. So when you get that acute clot formation, that's when you get that acute obstruction, where your flow to that part of the blood, to that part of the heart will be acutely decreased. Sorry, yes, question? Any question? Someone's raised their hand.
Dr. Najma, we will address the question at the end of the session. Yeah, sorry, you can continue with the lecture. Yeah.
Okay, just that people have raised their hands, that's what I was asking.
They're not aware with the Zoom properly, I guess. Sorry.
That's all right, don't worry. No, I just thought they had a question, not a problem. Okay, so just as a general, we'll go back to basics a little bit. It's useful to remember your anatomy, just because it's useful for ECGs and things. So from your aorta, which is, if you remember, your aorta is sending oxygenated blood. So from your aorta, you'll get your right coronary artery and your left coronary artery. Your left coronary artery further divides into the left anterior descending artery and the left circumflex artery. So those are the main things you need to remember. The smaller arteries are less useful in practice, but it's good to remember that, because we'll go through it a bit later on in ECGs and things, but those are the three that you need to be aware of. So when we talk about acute coronary syndrome, the main ones that we're talking about are unstable angina, NSTEMI, and STEMI. So we're going to go through them a bit later on in detail. But I think before you understand what unstable angina is, it's useful to know what stable angina is first. Is that something that you've gone through before? Okay, so we'll do it again today a little bit, very, very quickly. So stable angina very, very typically presents as pain, chest pain, precipitated by physical exertion. So whenever they go for a walk, they go uphill, they do the stairs, get a bit of chest pain, sometimes can radiate up the neck, up the shoulders, down the arm, feeling of breathlessness, and usually the symptoms relieve themselves as soon as they sit down. Very rarely you can get angina that can present with atypical symptoms, but we won't go into that today. And why does angina happen? Is because of that chronic, so angina happens because of this chronic obstruction that you get here from picture number 2. So you get this chronic obstruction that very slowly narrows the artery. And then what happens is, so if you look at this little chart here, not chart, whatever you call it, when you're at rest, your oxygen supply and your oxygen demand are fine. So the amount of oxygen being delivered to the muscle is enough to maintain that muscle, so the muscle is able to pump. But when you are exerting yourself, so most of us here, when we are exerting ourselves, when we go for a run, when we go for a walk, when we go uphill, it's still fine. Your body's able to adapt to that increase in demand. So your muscle's working harder, but your body's able to bring in more oxygen. In people who have that chronic obstruction over several years, unfortunately, they're not able to accommodate for that increased demand. So their demand is more than the supply. And that's because of the narrowing of the arteries that they're getting. And that's why they get symptoms when they're walking, when they're going up the stairs, when they're running and all of that. Once they settle and once they rest, the symptoms settle. So that's stable angina. Usually the way we treat it is we treat it with rest. So once you get the pain, sit down and rest. But we also can give them GTN, so glycerol trinitrate spray. It's usually you put it under your tongue, sublingual, it gets absorbed really quickly, and it's a vasodilator. So it dilates your vessels and can help increase the oxygen supply for a little bit. Because it's a vasodilator, you can get headaches from them. So some people aren't too keen to use them, but it's very useful to help with the acute symptoms. And long-term control, what you want to do is you want to get them on really good prevention. So get them to stop smoking, get them to have a healthier diet, get them to be more active. Start them on regular aspirin, because aspirin is an antiplatelet. So you want to prevent the acute thrombus from forming, that platelet formation. And then you also want to start a beta blocker. And what a beta blocker does is it slows down the heart, it decreases that stress that's on the heart. Further on, if the patient is still very symptomatic, you can do isosorbide mononitrate, which is a longer version. It's a slower release of GTN. So again, it vasodilates the vessels, but does so very slowly over several hours throughout the day. I hope that all makes sense. I know I'm rushing through the management a little bit. Okay, and other therapies that you can also do is PCI. So we're going to get through that a bit later on. And the other medications are very rarely used and very specialist. Okay, so we're going to do a little case. If you're happy to answer, good. If you're not happy to answer, that's fine as well. So you have a 55-year-old patient that comes to see you, and he tells you that he's been having worsening chest pain for the past 4 months. You know him already, and you know that he smokes quite heavily. He smokes 15 a day. He has a BMI of 34, but he is actively trying to lose weight. What else do you want to know? Is there anything else you want to know about his pain that he's getting? What specific would you like to know about this chest pain that he's been having over 4 months? Yeah, so you want to know what makes it, how long it lasts. What triggers it? So what triggers it? How long it lasts? Does it get worse with exercise? Lipid profile, yeah. So you can do that a bit later on, but just stay with the pain for a little bit. What kind of pain? Good, yeah. Can you pinpoint it, or is it diffuse? That's a really good one. So is it a pain that they can point at very specifically? They tell you it's here, or is it just generally everywhere? A pain that they can pinpoint at is usually more muscular and tends to be less of a visceral pain. Yeah, so generally you do your Socrates for the pain, that's good. Biomarkers, we'll come to that a bit later on. Yeah, so that's good. So generally your Socrates, good. So he tells you that his, the pain is just generally across his chest. It's brought on by walking, running. It's a very dull-like pain, sometimes goes up to his left shoulder, sometimes can have a bit of nausea with it and a bit of tightness. And it lasts for as long as he's moving. It settles once he's at rest. And it's happening quite often now. It's happening about 4 times a week, and it's about 6 out of 10 at its worst. Good, so we're going to come to the ECG and the blood exam a little bit later, but what do you want to do before you do an ECG, before you get to that, before you do a blood test? So you've just talked to him. What do you want to do before you get to an ECG? So before that, even before ECG, physical exam. So what are you looking for as physical exam? Yep, smoke cessation is good, but that's more in the management side of thing. So we're still looking at examining him, trying to figure out what's happening. What are we looking for in our examination? Throw random things at me. Heart rate, good, yep, very good. You want to know if his heart is regular or not regular? How quick it's going. Palpation, yep, so you can palpate his heart, see if there's a deviation in his blood pressure, good, and cardiovascular findings. So I'm just going to give you the, yep, good. Examination, what you're looking for, we went through this. So on your examination, you note that he's actually quite well at rest. He walks in, he's very comfortable. He's not in any respiratory distress. His blood pressure is slightly raised, 155/90. His heart rate is 84 and regular. And yep, saturation's 98% on room air, breathing well at a respiratory rate of 16, and his temperature is 36.8. You then move on to examine him properly, and you listen to his heart. You hear S1, S2, you don't hear any added heart sounds, there's no murmurs. His chest is nice and clear. Why is it important to listen to his chest here, even though we're talking about the heart? Anyone? Why are we listening to the chest?
Maybe subabnormal sounds we can hear in stable angina. So it's very important in people with a heart problem. We should do auscultation. It's one of physical examination for the not just heart problem and other problems too.
Yeah, good. But very specifically to him telling, having difficulty breathing or with the heart, what complications can you get of the heart? Cor pulmonale, that's the one I was looking for. But that was a very good answer as well. So you want to do a full examination, but you also, there are certain things you want to rule out when you're examining. In this case, you're listening to the heart. You make sure there's no bibasal creps. You want to make sure there's no fluids in the heart, in the lung. And that's correct. Everything else that you guys said have been. And does he have any other lung pathologies that's causing him to be breathless? That's all really good. His calves are nice and soft, non-tender, and no swelling. Why did I mention this? The calves are soft and not tender. Anyone can throw a guess? Yeah, edema, good. So leg edema, so that would be bilateral. And then, but there's also sometimes you can get DVTs, so clots in the legs, not so much related to his history, I agree, but general things you want to keep in mind. So at this point, knowing what you know about him, you ask for an ECG. What would you expect to see on the ECG? And what would you, and if you had, would you expect any ST changes at this point?
Yes, ST depression.
Why would you expect an ST depression? So he currently has no symptoms. He, at the moment right now, when he's with you, he has no symptoms. So what do you think he has? So let's go back a little bit. What do you think, what diagnosis do we think this patient has? Brad Peter, what do you think he has?
She has angina.
Angina. Do you think it's
Yes.
stable? Do you think it's unstable?
So stable. Well, we will ask about it.
Stable, yeah.
When
Because
I'm
According to the still,
he's only having it on exertion, but right now he's sitting there, he's nice and stable. Yeah, he's not having any pain. Would you expect any changes on his ECG at the moment? Now, you do one now.
No. Maybe after that, ECG will normal.
Yeah, correct. So at the moment now, he has no symptoms. So his ECG will be normal. So that's what we're going to expect to see, okay? And what about his troponin? Are you going to expect any change in his troponin? No, correct. That is correct. So that is, if there's one thing I want you to take home from today, is that stable angina, any patient with stable angina, they will not have any ECG changes and they will not have any troponin rise. And we'll go through that a little bit later about why they don't. But this is the ECG that you see. So let me just minimize this so you can see. Just answer in the chat, what do you think this is? Anything that you can see in this ECG? What's your diagnosis from this? Not diagnosis, sorry. What do you think of this ECG? So before we go to that, when you're looking at ECG, so when you look at an ECG, firstly, you see there are some things you need to see beforehand, okay? So when you interpret an ECG, you see if it's sinus, first of all. Correct, Dr. Nero, it is a normal ECG, but we're just going to go through the steps to understand why it's normal. So when you see an ECG that's put in front of you, you take it, you look at number 2. So you look at the rhythm strip down here, okay? Using the rhythm strip, you're going to figure out, is it a sinus ECG? Is it regular? Is there anything abnormal with the heart rate? So the heart rate to me here looks very normal. So what you would usually, how you calculate the heart rate, this is a bit of a recap for you, I know, but we'll go through it quickly. Calculating the heart rate is you count how many boxes there are between RR interval. In this case, it's 4. So 300 divided by 4 is your heart rate here. You see if it's sinus. So you can't have a sinus rhythm that's irregular, but you can have an irregular rhythm. Okay? So sinus rhythm, you can have sinus arrhythmia as well. So you can have irregular sinus. Sorry, my bad. I take it back. You can have an irregular sinus. But how you see if it is sinus is every P wave followed by a QRS complex. And in this case, every P wave is followed by a QRS complex. And there's a regular interval in between, okay? So this is a sinus rhythm. And then we're going to have a quick look at the ST changes. Can anyone, so some people mentioned earlier anterior ST changes. So whenever you see, so I can understand why you say that, but whenever you have an elevation, it needs to be more than one small square. In this, I know it's hard to see from this image, but in this case, it's not. And also, if you think, is this an ST elevation or not? Just remember, when you have a change in one of your leads, it should be similar changes in that area. So V2 represents anterior, as you guys know. You would expect to have changes on V3 or V4 or V1 as well. And we don't have any ST changes in V1 or V3 or V4. So this is not a true ST elevation, it's just a high takeoff. So this is a normal ECG, okay? The next one, I know this isn't an ECG class, so I don't want to spend too much time on it. So I'm going to skip this one just because otherwise we're going to spend too much time. Okay, now we're going to get actually to what acute coronary syndrome is. So we went through it a bit earlier. But so stable angina, you have that very, very chronic change. So in what image number 2 is, that very chronic buildup. In acute coronary syndrome, you get the break off of that little buildup here, and then platelets come and create a clot. When you create that clot, you get a very, very acute obstruction. That's the most common cause of all acute coronary syndrome. Much rarer causes is something like an embolism, so a clot's coming from somewhere else and coming to obstruct this area. Usually that's more common in things like infective endocarditis. Spasm, what I mean by spasm is if this is your artery, it just gets smaller. And that's usually more when people who do drug use, so people who use cocaine a lot, they tend to get chest pain due to coronary spasm. And dissection is just when it breaks, very, very rare, and tends to be more of a genetic connective tissue disorder thing. Okay, so the way we diagnose someone with acute coronary syndrome is the same way you diagnose everything else. You need to take a clinical history to know what's going on. From your history, you have your differential diagnosis, and then you examine them and see which ones fit your differentials. If you think this is ACS, you would want an ECG, and you would want biomarkers. Some places still use creatinine kinase, which is CK. So creatinine kinase is created by all your muscles. Whenever you have muscle death anywhere in your body, you can get a release of creatinine kinase. So it's not specific to the heart. It's very, very unspecific. So let's say you go out for a run right now, you run for 1 hour, you come back, we do your creatinine kinase, it will be raised because you've just used all your muscles. So the more specific one is troponin levels. And if you look at this graph here, we can see that once you have an acute myocardial event, so you have a heart attack or something, or you have an injury to the heart, you get troponin that's released, and it's released over several hours, usually peaks at about 24 hours, but each lab has it quite differently. So there's not one answer to all of it. Each lab does it quite differently. So usually what you have to do is you do a troponin when they come in, you repeat the troponin another 4 hours later or 6 hours, depending on your lab, to see if there's a change. If there is a change where it's going up, then you would think there was probably a injury to the heart because it's gone up. Okay, so now we're going to go to unstable angina. Now we're just going to talk about each of them specifically. So unstable angina is the worst version of stable angina. So you have angina that is prolonged and that is at rest. So people who have stable angina who are now resting and the pain is still ongoing. They are very unstable patients. They have a risk of having a heart attack, so myocardial infarction, in the next few hours. And the difference between a myocardial infarction and unstable angina, can anyone tell me what the difference is between unstable angina and a myocardial infarction?
Yes, I can. So in MI, always happen necrosis and heart cells injury, but in unstable angina, we don't have necrosis.
Good, yeah. So you have ischemia. So ischemia is...
Yes.
Ischemia means lack of blood to the area. Okay, so whenever you have not enough blood going somewhere, that's called ischemia. Necrosis is death of muscle, death of the cells. In unstable angina, it's not bad enough yet where the muscle cells are dying. Okay, but if we don't treat it, if we don't treat unstable angina, it will worsen to the point where you will get death of your cells. Let me just see the chat quickly because that is correct.
Also biomarker.
Yeah. Good. Sorry, I'm just reading. So, and then also clinically in unstable angina, you don't typically get, because there's no muscle death, because there's no necrosis, you don't very typically get changes on your ECG or troponin rises. So all of that can be normal. So it is very much a clinical diagnosis. What I mean by that is that it's your history taking and it's your examination that's going to tell you if this is it or not, okay? And then myocardial infarctions, like we said earlier, it's necrosis of the tissue. It can be transmural. So transmural is basically saying it's the whole muscle that's dead from top to toe, from top to bottom. And usually that would cause an ST elevation on your ECGs, or you can get non-transmural. So if this is your cardiac muscle, non-transmural is anything that is less than 70% or something, so it's not the whole thing. And usually you get ST depressions or T-wave inversions with that on your ECG. Okay, so differences in your, sorry, my thing is moving. Okay, differences in your from ACS. So we've gone through unstable angina and your myocardial infarctions. Your unstable angina, there is no change in your troponin and there's no ECG change, or if there is, it's very transient. So it's just and it comes back to normal quite quickly. With your NSTEMI, you get ST depression or T-wave inversion. And with your STEMI, you get ST elevation. And then we're going to go through a few ECGs in a bit as well. So I have a second case for you. So you have Elvis. He's 72. He comes to you because he's a bit out of breath. He has very severe chest pain and he's struggling to finish his sentences. He's visibly sweating. He can't really speak to you. What are you going to do? He can't speak to you.
Ma'am, we can ask from their family members about.
Yeah, good.
Yeah.
Very good. Yeah. So get a collateral history if you're able to. That is very good. What if there's no one here? So he's come to you by himself. So it's not always an MI. It's not always an MI. Other things can cause pain. Before we go to ECG and before we, so we can try and get some pain relief for him. But what's the first thing you'd want to do to assess him? So your vital signs. You must do your vital. You can't. Don't give oxygen if you don't know what his saturations are. Don't give anything before you know what it is. Okay, because even if he is having a heart attack, we know that giving oxygen, if his oxygen is normal, actually worsens it. So don't give oxygen before you've tested his pulse oximetry first. So in his case, that's what you do. His blood pressure is a bit raised, 180/85. His heart rate is 54, and he is saturating well on room air, so 94% on room air, and respiratory rate of 24. Okay, so I agree, giving him pain therapy, you want to give him something for the pain. What are we going to do next? So now we have his observations. What do you want to do next? So he has a lot of chest pain and all of that. So now we can go and do the ECG. Now I agree, let's do the ECG. So before we go on ECG, I'm just going to, so just coming to someone, Fatima, you mentioned aspirin. Don't give aspirin until you've diagnosed it, okay? Because you can have things like aortic dissection that can also cause chest pain. And if you give aspirin, you're going to make it worse, okay? So evaluate first. So as part of your examination, do your clinical examination first. Have a diagnosis before you start treating, okay? And someone mentioned controlling the BP. You can do that, but I don't think that's what's causing him to be in pain. And most likely his blood pressure is raised because his heart isn't functioning as well. So if you lower his blood pressure, he might just crash and not have enough blood that goes to his brain and things. So you don't want to mess with his obs too much until you know what's going on. Okay, so just coming back to ECGs. So I know you've done this already. We're just going to very, very quickly go through it just so we can remember landmarks and arteries. So ECG, you have your V1 to V6 that's put on the chest from here to the mid-axillary line on your left side. And then you have AVR that's put on your right hand, AVL on your left hand, AVF on your right foot, and AVL on your AVF, sorry, on your left foot. Okay. So when you are reading an ECG, it's good to know your landmarks, to know which leads represent which bits of the heart. So 3, 2, and AVF are looking downwards and looking from down upwards, sort of thing. So they're giving you an inferior view of the heart. Your V1, V2 is giving you a septal view. So V1 to V6 generally is anterior lateral, so from front to the lateral. V1, V2 is septal, although you don't really have to call it septal. And then if we go back to our arteries like we did earlier, so your right coronary artery is supplying the inferior bit of your heart. So if you have an inferior MI, you know it's the right coronary artery that's affected. Your left coronary artery divides into the left anterior descending and the left circumflex. Your left anterior descending covers the anterior and the septal area. So if it's just V1 and V2 that's affected, then you know it's just your left anterior descending. And your left circumflex, like the word circumflex, it's lateral, so it flexes into the laterals. So that looks at your V5 to V6, okay? So what do we think is happening here on this ECG? Sorry, I'm going to try to close the chat so I can show this to you. What do you think is happening here on this ECG? So this is Elvis's ECG that we've done. I'm going to let you guys have a look at it before I open the chat again. Good. Yeah. So, okay, good. But what I want you to do, whenever you do an ECG, it's easy to just go to the diagnosis, but just try to, so is this a sinus rhythm? So always start at your basics. Is it regular? Is it sinus? It is sinus. So what we mean by sinus, Raman, is that is every P wave followed by a QRS. And if you look here, every P wave on the rhythm strip, every P wave is followed by the QRS. P wave, QRS, P wave, QRS, P, QRS, P, QRS, P, QRS, P, QRS. And it's all regular between the RR intervals. So there is 1, 2. There's 5 boxes between them, and there's constantly 5 boxes between them. So it's regular and it's sinus. And then we go to the big changes, okay? So some of you mentioned ST elevation, that is correct. So there is ST elevation here in 2 and 3, AVF. There is a bit of a collateral change. So do you see there is a little bit of an ST depression in AVL with a T wave inversion? So what we're going to call that is, like most of you said, so it's an inferior MI. Is it a normal QRS complex? So it's not a normal QRS complex because it's a bit wider, isn't it? I can't really count the boxes here. It's 1, 2. I think it is so when you look at your QRS, you just want to see, is it narrow? Is it broad? That's all you really want to describe your QRS as. If it's, I think this is a narrow QRS. I don't think it's a broad QRS, to be honest with you, because everywhere else it looks narrow to me. If it's a narrow QRS, you stop there, you don't go any further. If it's a broad QRS, and that's if it's more than, can't remember if it's 3 squares or 5 squares, more than 3 squares, then you go and see, is there a bundle branch block left or right that's causing it. But if it's narrow, you stop there, you don't look any further, okay? So you don't get a bundle branch block without having a broad QRS. Okay. So this is your guy. You've done this ECG. You've diagnosed him as inferior MI. At this point, what do you want to do? So you've diagnosed him as having an inferior MI. And also just very quickly, so you see how there is the change in AVL. It's what we call contralateral changes. So you get the ST depression, and that's just to confirm that this is happening. So it can happen sometimes where you get ST depression in other leads when you're having ST elevation in some. So what are we going to do now? So it's not an unstable MI, it's a full-on ST elevation MI, because your ECG shows ST elevation. He has symptoms. So this is an ST elevation MI. What would you do at this point, though? What would you, so some people earlier said pain control and all of that. So now we know it is an MI. What can you do for him? What can you give him? Aspirin, correct? How much of the aspirin will you give him? 300, correct, yeah. So 300 of aspirin, we'd give the aspirin because it's an antiplatelet, so you want to prevent the platelet from worsening, but it also has an analgesic effect to it, and then morphine, correct? Morphine for pain relief. Okay, so you've given him that, and you are discussing with another doctor. Well, so just, Dr. Gul, you mentioned you would give him a beta blocker. Acutely right now, he has a heart rate of 54. So I wouldn't give him a beta blocker because you might make him crash. And also acutely, it's just probably not something you would give. Sorry, my battery is low, give me 1 minute. Okay. So you've given him this, and now you want to repeat your ECG. So you repeat the ECG to see if there's anything happening. And this is what you get. So what is happening now? Get the chat up. What do you think is happening? So start again. Is it regular? Do you think it's regular? So we'll come to statins a bit later on, and we'll come to blood pressure control a bit later on. I think it is. So it's difficult to say on this because we don't have a pen and paper, but I'm going to measure it using this. So if you all have a piece of paper, you can just use it to measure the distance in between. I think it's regular. There's the same space, the same distance between them. Difficult to say, do you think it's sinus? So I know it's not the biggest of his problem at the moment. There's other things going on, but is it sinus? Can you see? Yeah, good. So there is a P wave followed to a by a QRS. Good, good. So main changes, what's happening? What main changes are happening here? So earlier he was having an inferior MI. Now what's happening? Where is all his ST elevations? Where do you think the ST elevation is? Can you tell me which leads or which landmarks, I guess? What type of MI is he having? AVF, yeah, I agree. Lead 2, I agree. And lead 3, correct. And AVF, anywhere else? 2-3 AVF, anything else other than 2-3 AVF. So AVL has an ST depression and a T wave inversion, but how about those ones? How about V1, V2, V3, V4, V5, V6? What do you think is happening here?
We do.
In which ones?
In lead 2, we do.
Yeah, correct. But how about V1?
V1 also, I think, yeah, there's also an ST elevation.
So whenever you see an ST elevation, look at the others that also look at the same landmark. So V2 is anterior, isn't it? So we also look at V1. So it is. So that tells us it's now becoming an anterior.
When there's QRS depression, it should be ST elevation always?
What do you mean?
There's QRS, look, or it's normal?
The QRS, I think, is normal. I think the main thing here is that the ST elevation is so big that it's making the QRS look
it's normal.
abnormal. Yeah. So at this point, it is becoming everywhere. Yeah. So Niru, I'm going to take it. So there's no left bundle branch block here because I think your QRS is normal here. I don't think your QRS is abnormal, but there is a widespread ST elevation. So Elvis, who earlier we did an ECG on him and it showed an inferior MI, and now we're doing this and it's showing this. Either his MI is worsening, or like someone said earlier, consider tamponade or something. Yeah, but he's not good. He's not doing well, the guy. Okay. So now we have this ECG. This is a different patient, but we have this ECG. What do you think is happening here?
ST elevation and also not sinus rhythm, normal.
Yeah, so correct. There's no sinus. Very good. So it's very irregular, isn't it? It's irregularly irregular because you can't even find a pattern with it. So irregularly irregular, and it's not sinus. And how about QRS? Do you think QRS is broad or is narrow? Yeah, it's a wide QRS. It's a broad QRS. So now that we know it's a broad QRS, we can go to see, is there a bundle branch block that's making this broad QRS? So how do we now look for left or right bundle branch? How do we know which one this is? So why would you say left bundle branch block? Why do you call it a left-sided? What makes you know it's left? Fine. Okay. So the way I remember it is very simple. I don't remember the complicated ways. If you do, very good. But the way I remember it, is William and Marrow. So William and Marrow, what you're looking for is when it's broad, you want to see, is it making a W in V1 to V3, or is it making an M? And in V4 to V5, is your QRS making an M or a W? In this case, it's making a W here in V3, if you see the QRS, and then it's making an M in V6 and V5. And that's, so W initially, and then M. So it's William. William is left bundle branch block. If you had it another way around, where it was it was M in V1 to V2 and then W in V5 to V6, then you would call that a right bundle branch block. And the way I remember that is William and Marrow. I don't really know any other ways of remembering it, all the technical bits. Okay, so how do we manage someone with unstable angina? So if you remember, unstable angina is the first case we did. The gentleman who was having, we didn't do a case of unstable angina, sorry, but it's the one that you don't have.
Sorry, can you repeat, William?
Yeah, It's a bit complicated. Okay, so can you see the bit on the side, the William and Marrow bit? Or okay, yeah. So when you have a broad QRS, you look at the way that your QRS is going, okay? So look at here. Can you see my arrow, my pointer?
Yeah.
Yeah, okay. So just if you follow that, you just follow this. At this point here in V1, you can't really see if it's doing anything, okay? But if you look here in V3, you can see there's a little bit of a W here. And I think that's what one of your friends mentioned by biphasic. It goes up and it comes back down and it goes back up, okay? And then we're going to follow it here again in V4. Can't really see much. But if you look here, do you see how there's an M here? M here. And on V6, there's an M here. It's not a very good M. I know you have to convince yourself a little bit, but there is, it goes down and then it goes back up. So when you have W initially and then you have M later on, that's William. So it's left bundle branch block. But if, let's say, you had, let me just get an ECG up for right bundle branch block very quickly. And I'll show you what I mean. Sorry, my internet's very slow, so it's so if you go to the right bundle branch block ECG, it's very slow, sorry. Okay, so if you look at this one here, can you see it? Is it still sharing? Can you see the new ECG? Yeah. Okay, so if you look at this one here, so again, we can see that it's a broad QRS. So once it's a broad QRS, we see what way it's going. In V1, we can't really see much, but look at V2. It makes a nice little M. So whenever it's upward going, it's an M. Whenever it's downward going, it's going to be a W, basically. But it's an M here. And then in V4, you can see a really nice W. In V5, you can see a nice W, but a bit less nice. And in V6, you can't really see any W. But in this case, because it starts off with an M in V1, V2, V3, and then it ends with a W in V4, V5, V6, I remember it as marrow, and marrow R is right bundle branch block, okay? It's not very scientific, but it helps me to remember it. Okay, hopefully that makes sense. And let me just see the chat quickly. So any new left bundle branch block that you have in a patient is an MI until proven otherwise, if they have symptoms, okay? So if they're coming in with pain and what you see on their ECG is a left bundle branch block, you're able to see from their old ECGs that they were not, previously it wasn't a left bundle, they had a normal sinus rhythm ECG. So this is a new left bundle branch block with symptoms. It's an MI until proven otherwise. Okay, so management-wise, what we're going to do. So management is we're going to do unstable angina and NSTEMI first, and non-ST elevation MI. You want to give them aspirin, you give them high-dose aspirin. Again, that's to prevent that clot from getting bigger in the artery, or hopefully to help it break down a little bit. You give them, here in the UK, we give them fondaparinux, and I know each country does things a little bit differently, and each hospital tends to do things a little bit differently as well. So it very much depends on where you are and where you're practicing. But the general aim is that you want to give them something to break down the clot. Fondaparinux is a factor 10A inhibitor. So it prevents that clotting cascade from continuing, again, preventing that clot from getting bigger. And you give that subcutaneous as an injection. And then you give a second antiplatelet. Most commonly it's clopidogrel at 300 milligrams as well, but the newer type now is called ticagrelor. It's newer, it's more expensive, it's not used everywhere, but it's good to be aware that there are different types of antiplatelet that we use depending on where we are. If the patient is unstable, and what do I mean by being unstable is if a patient is developing heart failure. So if they're not able, if their symptoms are so bad that they're not able to compensate for it, so they're going to heart failure, they're getting fluid on their lungs, they're getting edema quite badly and quite quickly, then that's an unstable patient. If their blood pressure is dropping, if their heart isn't able to pump, then you want to send them for PCI immediately. PCI is percutaneous coronary intervention. It's where you just put a stent in to open up that artery. If they're stable, here in this country, we usually say a PCI within about 3 days. But again, depends on where you work, depends on facilities available to you, and on services available. In many, many countries, PCI isn't available. It's not a widely available system. So then what we do is thrombolysis. And we use alteplase for that. So thrombolysis is basically just a high dose of an agent, usually alteplase, that will help break down that clot. Works okay, but has a higher risk, has much more side effects because you're giving them anti-clotting agent. They have a risk of bleeding. They have a risk of bleeding in their brain. They have a risk of bleeding in other places. So it comes with more risks. So if you're able to, we try to avoid thrombolysis and do a PCI if able. Okay. And this is basically what the percutaneous coronary intervention is. They go through an artery, usually it's either the radial artery or the femoral artery. They push it through. They have a little camera and they'll inject dyes, they'll take x-rays and things to see where the obstruction is. Once they find the obstruction, they push in the stent. And once they got the stent where they want it to be, they open up the stent and hopefully get the plaque settled then, and increase the flow to that muscle again. That's correct, yeah. Most countries in the US, I don't think the US would ever do a thrombolysis nowadays, but I'm in the UK, and so I work in England, but I have a friend who works in Wales, and they still do thrombolysis there because it's too far to get to their closest cardiac center. So it's not as worn out as you would think it is. Quite a few countries are still doing it, unfortunately. Okay, so this is just our guideline in the UK. I've put it on there. I don't know if it's useful for you, but it just basically summarizes what we do. And if they have an ST elevation MI, so if you remember an ST elevation, it has a transmural necrosis. So they're losing muscle very quickly. They're losing cardiac muscle very quickly. So again, you load them with aspirin, 300 milligrams. You don't give them anything else because you would want to get them into PCI within the next few hours. And if you give them fondaparinux and things, then you're increasing their risk of bleeding during that surgery. So you try to avoid it. But if, again, if not available, you go for fibrinolysis. And that's, again, the guidelines that we use here. And then you guys mentioned quite a bit statins and beta blockers and things, and that's all very, very true. It all comes in, but it comes in a bit later on. So it's not in the acute phase. Acutely, you don't do statins and things, but you do it a bit later on. So once you've gotten them, you've put a stent in, you've gotten them up and going, they're now pain-free. You want to prevent that stent from getting obstructed again. And you want to, what do you want to advise your patient at this point? What do you want to tell them to do to prevent the risk of a new heart attack? Where's the chat? Can't get the chat. Here. Avoid smoking. Yes, all of them should stop smoking. Not all of them do. A lot of them don't. But yeah, weight loss, correct. So very decreased weight, get a healthier diet. So actually you want them to exercise more, but gradually exercise more. So don't do a marathon straight away from after your MI, but very slowly, you know, start walking a bit more, start running a bit more, do all of that. Yeah. Sugar control, so you want to do all, perfect, that's really good. And medication wise, so what do you want to do medication wise?
Aspirin.
Aspirin, yeah. What dose are you going to do it at?
First at the 300 at the first, but after for the rest of life, 75 milligram. Correct.
Yeah, 75 for the rest of life afterwards. And then you want to do a statin. A statin, that's just to prevent that cholesterol deposits. What is this? We also start ACE inhibitor. So that's something like Ramipril. You want to start a beta blocker at this point to decrease the amount of stress that's on the heart. And then you do dual antiplatelet initially for 12 months. So that's aspirin with something else. And again, the other drug depends very much on where you are in the world. But for the longest time, we did aspirin with clopidogrel for 12 months. But now we are moving to aspirin and rivaroxaban, weirdly, which has just gotten licensed for this purpose. And then you do a statin. So every patient that's had an MI should be on those, at the highest dose that they can tolerate for the ACE inhibitor and the beta blocker, and for the antiplatelets, 75 milligrams of aspirin and clopidogrel. And then this depends very much on where you live, but in this country here, you're not allowed to drive after you've had PCI for 4 weeks, and then after that you can drive if you're stable. If you're a heavy vehicles goods driver, you're not allowed to drive if you have angina in general. Flying wise, it's something you need to discuss with your airline, and but the usual advice is for 10 days you're not allowed to drive, to fly. So no lifting weights. I don't think there is a blanket rule about lifting weights or not. I think it's more that you don't do, it's about doing moderate changes slowly, not going from doing nothing to suddenly lifting 500 kilograms. Slow, moderate changes to allow your body to get used to it. And that's what we call cardiac rehabilitation. So you're meant to have a bit of slow exercise, so walk a bit more every day, just to build up the tolerance, build up the heart exercise. And I think that's the end of it. Any questions at all?